Perfect. Thanks very much for inviting me to this conference. My name is Antonia Lannie. I'm a lecturer in cancer and palliative care at the University of Dundee, and I'm honoured to present today. So I'm going to present a study which is surrounding the older person with cancer and looking at professional and patient perspectives on a person-centred approach. So really the background to my study is actually going to talk about the context of the issue. Why is this a problem? Then I'll go into the research questions, the methodology, which is qualitative, and then to actually go into the findings. And I'm going to focus on three findings, which is the care environment, emotion work, and hope. And then I'm going to look at the recommendations for practice, which is holistic care and engaging authentically. And then there'll be a summary. So older people with cancer are disadvantaged, and I'm sure this just isn't only in Britain, but in other countries. And this is really because hospital, community and care homes lack education in older people with cancer, particularly in understanding disease processes, frailty, isolation, depression, delirium, dementia and multimorbidity. And nurses have a critical role in maintaining the optimal health and quality of life for older people with cancer. However, there's insufficient attention has been given into the development of the nursing workforce and how to provide it. Healthcare professionals tend to be paternalistic and undertreat or overtreat. Patients are cared for in diverse care settings, and this leads to a sense of not belonging for people who are repeatedly admitted to different care settings. And therefore, there's no specialist area for the older person with cancer. There's also a lack of shared philosophy of care, and findings revealed the challenges of non-specialist wards have in relation to the needs of older people with cancer. There is little recognition of the gero-oncology concept, which Sarah Kagan in Pennsylvania in 2008 promoted this concept of gero-oncology, which encompasses the physical and emotional aspects of a life mostly lived. And I'll be demonstrating that in my findings. Decisions are made on a basis of chronological age rather than looking at the frailty and the unmet needs. So therefore, there is a lack of assessment. So the scope of the problem is really, and I'm sorry, the text is a bit small there, but 65% of patients with cancer over 65, but there's a projected increase to 50% of that as people are over 80. 45% live alone in Britain, and there's a potential for social isolation. There's less access to screening. They're diagnosed later due to anxiety, and male people are perhaps more reticent to go to their GP than females, so there's a gender bias. There's less rigorous staging, and there's less aggressive treatment. And there's a lower rate of survival and cancer mortality, which increases, sadly, with age. So it's a real complex problem here, and it's to stay. So following all these issues that are problematic, I wanted to touch on what we really need, and that is a person-centred approach. Now, I've bolded up the words consciously, because it's an approach that consciously adopts the perspectives of individuals, families and community that respond to the needs and preferences in humane and holistic ways. So person-centred care requires that people have education and support to make the decisions and participate in their own care. So it's around expectations of people rather than diseases. And I'll go later on into the expectations of people when I go into the theme of hope and the attributes of person-centred care. Now, I've also based my findings, or rather I've scoped my findings after I did my findings, I looked at the theoretical models of person-centeredness, and this framework became very helpful for me because it looks at the macro context, our health and social care policy, but then the other layer is looking at the prerequisites. So what do we need to deliver person-centered care? We need to be competent, we need to have shared decision-making, but we need to have outcomes that is in the middle of the flower in the centre. But the two I want to focus on is how we provide holistic care and engaging authentically. So that's 10 to, if you think of a clock, it's 10 to the hour and 10 past the hour are the two aspects I'm going to focus on today. So my research questions are, what is to explore the lived experience of the older person with cancer in 2 ward settings. And I focused on a haematology ward, and I also focused on a medical ward. I wanted to look at professionals' views on care delivery. What are the professional roles and responses to this care delivery? What are the psychosocial experiences of older people with cancer? And to explore the interpersonal dealings with patients and professionals, and really how these questions are aligned to person-centered care. So my research design is qualitative, and looking at a medical and a specialist cancer ward gave rise to slightly different challenges for patients and healthcare professionals, depending on whether the focus is on the older person or cancer. So nurses work within different focus of care and have different experiences and education, which affects how they manage emotions and patient symptoms. And I'll go more deeply into that when we explore emotion work. So my sampling strategy through this Venn diagram demonstrates the comparison of 2 wards, and purposive sampling of healthcare professionals and patients gave diversity to the sample. For example, there was fortuitous opportunities for comparison, such as a patient who described himself as a connoisseur of wards. There was also a nurse in the cancer ward who was actually a patient in the ward. So there was lovely stories, which I'll also go into later on. So the study involved initially 2 focus groups in each of the wards with professionals. I then carried out 10 semi-structured interviews with patients, and then 10 healthcare professional interviews. And then I carried out dissemination focus groups, which was really to help member checking and to gain further reflection on data. So I basically presented my results to the members of both wards, and they gave me great insight, as to the analysis. So the next slide is actually demonstrating the experience of living with cancer being older, but also the person with cancer. So it's the perspective of the older and the person with cancer, looking at the organisation of care at its higher level, as in policies, work environment, personal, professional perspectives, and the professional perspectives interacting with the people's life worlds. Okay, so my findings, the 3 findings I'm going to discuss are the care environment, emotion work, and hope. So the care environment, so it's really looking at the organisational culture, which is focusing on emotional space, time, and personhood. We are living in a culture which has increased emphasis on targets, the increase in treatment options, and technological care. And we somehow look to the professionals of being technically competent rather than perhaps being person-centred. We really need shared decision-making between geriatric and oncology to assess and plan care. And there's a need for an interdisciplinary approach, such as using the comprehensive geriatric assessment, which I'm not sure if you know of, but it's an assessment process when looking at the older person, and also to provide age-appropriate care. So there's emotional and physical safety surrounding this relational care. But we have to ensure that there is certainty when people are living with uncertainty. I'm next going to show you some quotes from my study. So I'll let you read there, David. David had leukemia. He was on the specialist ward. And he said, "Will I be safer here or in my own house?" And ironically, you always feel safer in hospital. And when you want to go home, you want to come back into hospital. So I realised that there was an a priori code here called the halfway house. And I called that because the clinical area provided a safe haven for David. But they also found that they needed clinical help. And in the haematology ward, there was this permission to ask, which is reflected in staff nurse Crease's quotation when she said, "The patients receiving chemotherapy feel safe here as they often go home to an empty house. When they phone and say, 'My tooth is sore, will I come in?'" So it's actually saying that there's a trust and mutuality built up on the specialist ward because there's repeated admissions. They don't have to go through A&E. They come right to the specialist cancer ward, and that makes them feel emotionally and physically safe because they really treat the staff on the specialist ward like family. This is a lovely quote, and it's pulling on Kagan's work about a life mostly lived. And this is Archie saying, "In between, I've had 2 broken hips. I was here with my hips. I've had my hips replaced. I'm not long having had heart disease and prostate cancer too. I'm not long finished with prostate cancer, and my wife died on this ward, so I'm not a stranger here." And I was really amazed by Archie's resilience and also how he perceived his illness now. And it made me think once again that he's not perceiving himself with his current illness. He's not regarding his cancer as such a biographical disruption, as he's already had many things going on in his life. So I thought that psychosocial aspect was very particular to older people with cancer. And this is reflected in Maggie when she says, "I don't let this illness shape me. I want to be remembered as the best grandmother who made the best jam buns." And jam buns are quite famous in Scotland, by the way, and they're very sugary, coaty things. And so this is Maggie once again demonstrating that she's a grandmother and she's a good cook. And this was always reflected in other patients' accounts as the big biography of the person forms how they look to the future. And it was almost like a social construct of being older can also blur the hidden person behind the disease. And that was so important to ensure that people saw themselves as people rather than the older person with cancer. I just wanted to bring in realistic medicine here, and Barnett et al. Demonstrated with the realistic medicine that we really have to live well with long conditions. And, we have to consider multimorbidity, polypharmacy, symptom clusters, and frailty. And we have to look at the trajectory of dying with different illnesses, because not only do older people have cancer, but they might have COPD as well, they might have heart disease. So therefore, looking at the best supportive cancer and palliative care is so important. And I don't know whether you can see about the dying well section at the end. This is just so important. So holistic assessment is key, as is the awareness of prognostic awareness. But also there's something else that I wanted to bring in, and this is about emotion work. It's about how we as professionals can be there. Now, this is talking about the relational therapeutic nature that nurses and patients do demonstrate on both these wards. And this emotion work was undertaken by patients and professionals, and I'll go into that in more detail. I also wanted to theorise and say McLaren described emotion work as anticipating and seeking how to manage people's feelings. And it's almost like work that is undertaken by professionals and patients. So this is an example of how a nurse was with that person. She said, I think a lot of them find it a privilege that they trust you. They trust you so much. It's a great privilege. And you try and do your best. And that was a long CNS. And staff nurse Chris talked about sitting with them, taking them to the toilet, and they say, I want to give up. And I say, why do you say that? So it's just being there. We would not have that opportunity otherwise. And that pulls on the theoretical theories of Malone, which is an American framework, and Nolan, the census framework. So through this physical proximity and increased time with patients and professionals emphasises the uniqueness of the being with that person and the therapeutic benefit of giving direct care, which nurses have the privilege of doing. But as I was saying, the patients actually also underwent emotion work. And Alexander, I remember he was so brave when he said, his family, will look after her, no doubt about it. You won't need to go to the undertaker or break her heart or anything because everything has been done. And Alexander was very keen to have advanced care planning. He wanted, in actual fact, to have it framed next to his bed. He was so emphatic on getting this sorted. Ginty was the nurse who then became a patient on the ward she actually worked in. And she also looked to other people, and she said, there's always someone, worse off than me. And Ginty used the process of comparing to others to enable her to feel better about her illness in a way, because she was older and she thought, she had a good life. So patients do undertake emotion work, but so do professionals. Now, these three quotes demonstrate the different levels of emotional engagement. So staff nurse Chris said, we are clowns that change our faces. And this to me was quite a superficial engagement. It made me think, goodness, she's changing her faces to what the patients want. But maybe that is something that professionals do to try and get through. But also the important thing is people do reflect. And staff nurse Jones said that. She said, I think it's really hard if they get a diagnosis because you're nursing them and you don't think that their condition is that bad because they're masking it to a certain degree, as older people tend to hide their pain. And if they get a diagnosis of cancer, then it's very hard because you think, my God, how can that be? And I think their staff nurse Jones was really reflecting. But staff nurse Jenkins demonstrated quite an authentic part because she said, if you've experienced, as you say, a loved one with cancer, that informs how you care for a patient. And I labelled that as authentic engagement. So basically, the emotion work that I saw was at three levels: a superficial, a reflective, and an authentic engagement. And this made me think of dignity, which Max Chochinov from America had developed. And we've really embraced Chochinov's work. And it's the patient dignity question. What do I need to know about you as a person to give you the best possible care? And staff nurse Jenkins reflected on that. And she was saying, it's listening to them, keeping them safe. Even your emotions get involved because it could be your family, it could be mine, it's difficult. And I think when you are authentically engaging with patients, you do work in this way. dealing authentically with patients leads me on to the last findings before we go into the recommendations, which was about hope. Hope was a concept that was relational. It was developed over time. It looked at the wants and expectations of people, and it worked with advanced care planning. It took emotion work as realistic goals were managed. And I just thought I'd go into, the patient who was talking here about past losses, and she really hoped that she went like her husband. I hope I die like my husband. I hope that it is my heart that goes first, like my husband. And I remember her saying she really didn't like dying of cancer because she had lung cancer, and she was really breathless and frail. And then on the dissemination focus groups, this quote was very much about, you take on a paternal role with the younger ones. You find the older ones will be comforting some of the younger ones and offering them their experiences. So there was some hope work going on there as, older people were negotiating some kind of hope with the younger ones through comfort. I also want to bring in Wiles's work here, which talked about generalised and particularised hope. And generalised was very much about, I need chemotherapy, I need that, to help me. You have to, chemotherapy was grabbed with both hands as people wanted to have hope through their treatment. Whereas in the dissemination focus group, there was this talk about not going to live long, as they were denying that because they were hoping, but this was their hope. So it was actually saying, do you know what, I don't want to live this long. So it was almost like a generalised hope of, please give me chemotherapy, but there again also the sense of, I want to die. There was collegial tensions in delivering hope. And this was really, as Staff Nurse Jones said, in talking about, should you be getting chemotherapy or radiotherapy? And then the doctor comes back and says, no, you're not getting anything. And then, the nurse reflecting and saying, yes, but the nurse said. So it's almost like making sure that there's a same message and that hopes aren't crushed. And Staff Nurse Gamblin, reinforces this and says, you have to stay stum sometimes and say nothing, because it might be false hope that you're giving. So I'm going back here to the two petals, providing holistic care and engaging authentically, and just to talk about the recommendations for practice based on what I've discussed. So, providing holistic care is really about ensuring that there is symptom assessment, such as development like the Rotterdam quality of life tool, looking at symptom management, looking at symptom clusters, how depression affects appetite, how appetite affects tiredness, and so on, looking at prognostic indicators, looking at the comprehensive geriatric assessment and looking at quality of life tools such as the EURTC. And all these things can be worked together through this therapeutic relationship and emotion work that I've been talking about. That's just an example of a palliative performance scale which we have, but I'll move on quickly because I think I've got 1 minute to go. Recommendations for holistic care is using the palliative performance scale, but it's also about educating people on this gero-oncology. There's a need for cancer to be situated with the older person. I work with the European Oncology Nursing Society, where we've developed a curriculum looking at gero-oncology. So that's, if you want to look at further work, that's on the EONS framework. And also to look at clinical nurse specialists and the value of having a gero-oncology nurse. Recommendations are also about emotion work and the importance of dignity. And these Schwartz rounds was from a person called Edward Schwartz, who died of cancer. And his last words we're really recommending people to reflect on their care delivery and to have reflective times as a multidisciplinary team. Person stories are also so important to ensure we contextualise the present and the future, so we understand the personal biography of patients, and as Sarah Kagan said, to integrate cancer into a life mostly lived, and to look at what matters to the person and look at advanced care planning. So in summary, I've discussed where the older person with cancer matters. Holistic assessment is key. Patients and professionals must engage in emotional work, which is hard work. But to do this, we also must acknowledge the importance of authentic engagement and to understand the person behind the disease. Thank you so much for listening to me. And I've got references there just to follow up on what I've been discussing.
Thank you, Dr. Antonia. That was a very wonderful presentation.
Yeah. Thank you.
If anyone have any questions or comments, we quickly ask Dr. Antonia.
I'm trying to share my screen actually. I can't see myself, but I don't know whether I'm there. Yeah, any questions?
Yeah, if anyone have any question, we'll quickly ask Dr. Antonia. If no questions, we'll move ahead with our next.
It was excellent.
Oh, thank you. Who's that?
Oh, Ann Berger.
Hi, Ann. Oh, thank you so much. Thank you.
Yeah, so we'll move ahead with our next presentation.
Was this for a degree or?
This was as part of my PhD. Yes, that's right. So
okay.
I've since gone on to look at our study, looking at the older person with frailty in diverse settings. So really not looking so much at cancer, but at frailty, and looking at the indexes of frailty and how people assess frailty. Yeah.
It's excellent.
Thank you for very interesting topic and good presentation, and also thank you for the earlier presentations. They have been very interesting, all of those.
Thank you.
Thank you.